Okay, so first, I just want to thank you all for joining our webinar today, the Accurate Accreditation's Life Safety 101 for Medicare Survey Preparedness. Again, if everyone will please stay on mute, you can keep your videos turned off, and then questions can be asked in the Zoom chat, and those will also be addressed at the end of the presentation. So first and foremost, I would like to introduce to you all Marge McFarlane. She is a life safety specialist that was so kind enough to do this presentation today. So Marge, I will let you take it from here.
Thank you so much. So I come to you with many decades of healthcare experience, and most recently in the ambulatory surgery center, but I've been doing life safety surveys since 2005. And I am currently working with healthcare systems, ambulatory surgery centers, and clinics nationally to mitigate risks in the physical environment. So my PhD is in safety engineering, and I come from the laboratory. So I'm a fairly detailed person, and I became the safety officer of my hospital in '99. And now I am out and about chatting you up about how do we prepare for a Medicare survey and ensure that all the life safety features are addressed. Next slide, please. We want to talk about the CMS conditions for coverage, and that would be focused in Appendix L and Appendix I. We're going to discuss the risk assessment required by NFPA, the National Fire Protection Agency, Chapter 99, Chapter 4. I find that when people are asked from accrediting bodies to classify their risk assessment, they don't understand what the question is being asked. I'm going to talk about what does deemed status mean versus CMS accreditation. I have a list of challenges in managing the life safety features of an ambulatory surgery center. And the biggest challenge I can tell you right off the top of the head is that you all wear many, many hats. And it's really hard to get down to the details of all of the things that are required for life safety. I have a list of frequent findings that as I go out and do surveys of ambulatory surgery centers, frequent findings that you can address, and know that the list of questions is next slide, please. All right, so life safety codes. What do we want to know about life safety codes? And the most important thing is that these are regulations for building requirements to protect our patients and staff from smoke and fire and the products of combustion. So when we talk about life safety, fire is the issue. And how our buildings are built depends on the occupancy type. And that really relates directly to the patient's ability to self-rescue. So in our ambulatory surgery center situations, if we are using general anesthesia, inhalation anesthesia, those people cannot get out of the building by themselves. And that is what CMS is taking a look at and saying that those are the people that cannot self-rescue. When you think about people coming in like in a wheelchair, they usually have somebody pushing the wheelchair. Now they could technically not self-rescue either, but what CMS is talking about is that you've altered their state of consciousness by giving them some anesthesia of some level. So the life safety codes have been adopted by the Centers for Medicare and Medicaid Services since 1967. And what they have done is they have moved and upgraded as we have new building regulations, and sprinklers is the biggest one that I can think of. Currently, Centers for Medicare and Medicaid has adopted the Life Safety Code, NFPA Life Safety Code 101, 2012 edition, and the Healthcare Facilities Code 99, the 2012 edition. And that was adopted by CMS on July 5th of 2016. And the reason that date is important is if your building was built and approved prior to July 5th of 2016, you are considered existing. If your plans were approved after July 5th of 2016, you need to follow the new chapters. So when we look at NFPA 101, Chapter 20 addresses new ASCs. So I need travel distances, I need special med gas building. I mean, there's just new. If I am existing, then Chapter 21 addresses how my existing ambulatory surgery center can be built. When I think about NFPA 99, this is the first time NFPA 99 has been law. It has been adopted by CMS and it is law. And so it addresses new and existing ASCs by a risk assessment for patient harm. So I'm sure that some of you have been asked, so what is your risk assessment? Are you a category 1, 2, 3, or 4 facility? And the definitions are here on the slide. And the most important thing to know is if you are using general anesthesia, you're a category 1 facility, meaning if the power goes out, the anesthesia machines will not be breathing for the patient, and it could cause major injury or death of patients or caregivers. And so you need a type 1 generator, and you need a category 1 or type 1 duplexed medical gas system. Category 2 talks about if the utility systems fail, then the equipment that doesn't run because you have no generator would only cause minor injury to patients or caregivers. So most of the time I see people in the category 1 facility. Category 3 in some existing facilities can be maintained when the equipment failure is not likely to cause injury to patients or caregivers, but could cause discomfort, meaning you might not have your HVAC system running. But in all cases, and there is no category 4 in ASCs today, but in all categories, somehow you need emergency exit lighting. And so if you don't have a generator that's providing you emergency exit lighting so that you can get remove yourself from your building, then you need battery backup lights. And that's where all of those things come in. So these codes then, 101 and 99, identify how you are constructed, that you need a fire alarm system, that you need sprinklers, that you need generators. This talks about all your air pressure relationships, your humidity requirements, your egress, which is the path to get out of your building. It talks about storage, which is combustible, and how do I build my building so that the storage doesn't impact the way I get out of the building. And then it talks about emergency lighting, fire extinguishers, drills, and staff training. Now, even if you are in a business occupancy, some ambulatory surgery centers are kind of connected to clinics. And so doctor will see people in clinic, and then they have a surgery center attached. So the construction type of your building of the clinic is different. But in all buildings, all healthcare, you need emergency lighting, fire extinguishers, fire drills, and staff training. It just depends on the frequency of those activities. Next slide, please. Okay, so this is a copy of the CMS memo from the Clinical Standards and Oversight Group. And this one was published in June of 22. And it just kind of updated some of the discussion to ensure that people understood that they needed separation from other occupancies. Okay, so Appendix L talks about standard for the physical environment. And this is the conditions for coverage that if you are taking Medicare money, you need to comply with. And then the Q talks about immediate jeopardy, which is different from patient safety in that we are talking about building immediate jeopardy. And so physical and temporal separation is something I see that people have some confusion about. And so if you have an ambulatory surgery center, then only the ambulatory surgery center can be in the waiting room and can be in that space while the ambulatory surgery center is open. You cannot share corridors, supply rooms if they are within the 1 hour fire rated area of the ambulatory surgery center. And so the whole appendix L and Q and I are written with, this is the standard. And then it has survey procedures and it talks about interpretive guidelines. And so when you look at the interpretive guidelines, it will list the questions the surveyors are going to ask you. And this is why I've said this is an open book test, because we can predict what questions they will ask. Now, the survey universe is many, many, many questions. So depending on the knowledge of the surveyor, the experience of the surveyor, your past deficiencies, the size of your ambulatory care center, and the level of anesthesia that you give, they will pick different questions, but they will always talk about 1 hour separation. They will always talk about fire alarm. They will always talk about generator, and they will always talk about sprinklers. Next slide, please. All right, this slide has a lot of information on it, and you will have access to this slide, but this is the meat of the questions that cover life safety. And so when we look at conditions for coverage, so the Q0101 standard says the physical environment, the ASC must provide a functional and sanitary environment for the provision of surgical services. That is the condition for coverage, and everything else falls underneath that. So when you have a condition level finding, it means that some thing in this following discussion or a compilation of those, or they all roll up, and then you have a condition level finding, which means you get a repeat visit. And so it talks about designing operating rooms for the appropriate type of surgery. And it clearly talks about, they use the word operating room in an ASC, but it could also be a procedure room. So it's not just the traditional OR room, but it talks about being designed for whatever you're going to do in that space. And it could be sterile or not sterile. Existing ORs need to meet the standards that were adopted at the time they were constructed. And the biggest difference I can think about is air exchanges for ORs. Existing ORs have 15 air exchanges. New ORs have 20 air exchanges. So if you have an OR that was built with 15 air exchanges, you need to save that documentation. So when the surveyor comes and says, show me the test and balance, and that you meet 20 air exchanges, you can say, no, we were built under the code of 15, and here is the documentation to provide that. So on the right-hand side, it really talks about how are these rooms designed, and they are designed by such guidelines as the Facilities Guidelines Institute or your state's licensure requirements. And so you just need to know what rules you need to follow and have that construction documentation available for the surveyor when they come. So you want to be sure that that you are looking at infection prevention as well as life safety issues when you are in an OR. Okay, so infection prevention issues deal with pressure relationships, temperature and humidity, surfaces and cleaning. Life safety talks about clear access, smoke-tight barriers, doors that close and latch, as well as lighting, generators, air handlers, med gas systems, air compressors, vacuum systems. So all of those things go into this package that we call an OR. And so when the life safety surveyor comes, those are the things they're going to be focused on. And so the biggest challenge I see is that temperature and humidity and airflow is not being maintained to acceptable standards. When I go, you do the tissue test, and I have found ORs that are out of balance. They haven't been balanced annually as required by CMS, that they aren't doing a tissue test routinely in the ORs to be sure. Now you may say, oh, Marge, we've got that nailed. And we know that our pressure and our humidity are correct all the time. And I say high five and good on you. That's good, safe patient care. The biggest challenge I have seen recently to humidity is that CMS has stated that the ORs and sterile storage need to be maintained between 20 and 60% humidity. And in 2019, but prior to 2019, Amy had said sterile supplies are good up until 70% humidity. And they deferred then back to CMS and to ASHRAE, which is the American Society for Healthcare Engineering of Hospitals, and the Society for Heating, Refrigeration, and Air Conditioning Engineering. And so when you think about who's in charge, which rules supersede other rules, because 70 in some locations is much easier to maintain than 20 to 60. And so the requirement is that law and regulation start, and then CMS guidelines, and then things like CDC, and then consensus standards. And so the ASHRAE standard is a consensus standard, and Amy is a professional standard. And so Amy said, okay, fine, we'll go with the facilities guidelines. So your ORs and your sterile storage areas need to be maintained between 20 and 60%. So as I'm out touring, I look at those logs, and at the bottom, it'll say the acceptable range is up to 70%. And so you need to revise some of those documents if you still are looking at that as acceptable. The other thing that CMS says, and is a challenge to all of us, is the 20 to 30% humidity. In the beginning, CMS said all your rooms needed to be between 30 and 60. Okay. And the purpose of being between 30 and 60 was that there was no static shocks in the ORs, because we used to have flammable anesthetic agents. We have used non-flammable anesthetic agents as long as I have been in healthcare. And someone said, well, why can't we have the humidity down to 20%? And CMS said, go for it. And then manufacturers of equipment said, oh, we did not test our equipment down to 20%. And we require that you store these products and equipment between 30 and 60%. So the Bovie-Dick indicators that we use for steam sterilization, if you look at the package, it says you have to store it between 30 and 60%. And there's also other equipment that needs to be stored between 30 and 60%. And so you can't do 20. And so CMS says, if you are going to just do a blanket 20 to 60, then you need a risk assessment to be sure all your materials and your equipment are allowed by the manufacturer's instructions to live between 20 and 30%. And so my recommendation is, if you can maintain 30 to 60, go for it. It's much easier than continuing to do an ongoing risk assessment for anything new that you might get. The other thing I want to say is that when things are out of balance, when you have deficiencies in temperature, humidity, or airflow, you need to do that infection control risk assessment to be sure that all your sterile supplies that are in those areas are still okay. I do not think that temperature has that much to do with non-sterility, Marge's opinion, of supplies. Okay, but as you drop the temperature, your humidity will increase. And then when it's raining on the walls and you have moisture on your packages, that is when there's sterility issues with all the sterile goods that you have in those rooms. Next slide, please. Thank you. All right. Q0104 talks about fire. We've talked about infection control, and now we are going to talk about fire. And
Yeah, well, on Friday, that's rock off there on Friday. He goes, that was huge.
Excuse me. Somebody's unmuted. We'll talk about fire. And so CMS says that we need to follow NFPA 101 and 99, regardless of the number of patients served that cannot self-rescue. If you look at the language of the life safety code, it says when 4 or more cannot self-rescue. All right, but CMS has interpreted that differently. And so we need to be sure that we meet these fire requirements if any one person cannot self-rescue. It talks about if your state has codes imposed by state law, you follow the state codes. Otherwise, you follow the NFPA 101. It talks about alcohol hand sanitizers may be placed in dispensers throughout the facility, and this is a fire issue. And so before COVID, they were very picky about where alcohol-based dispensers could be installed in clinics, in ambulatory surgery centers. And what they have done is they've loosened that regulation, and there's an amendment in the life safety code that says we can have alcohol-based hand rubs around. And so if you have any area that's carpeted, you have to be sure that you are sprinklered. And so again, since the COVID pandemic health emergency has ended, all of those stands that are in the hallways need to be reassessed, because you need to be sure that you have a clear path of exit, and that there's not too many hand sanitizers. They have to be 4 feet apart, 1 inch above or away from electrical shock, and they all need to be protected from vulnerable populations to be sure that your behavioral health and your pediatric populations cannot get a hold of those alcohol hand sanitizers. All right, next slide, please. Thank you. All right, I just wanted to talk briefly about deemed status and understanding the survey process. So we've talked about the background. Where do the rules come from? And you go like, oh, that is so overwhelming. Okay, so now we're getting into the practical application of what do I need and where do I find it? So know that Centers for Medicare and Medicaid Services write the conditions for coverage for ambulatory surgery centers. And so you can apply to Medicare and be surveyed under the life safety portion for Medicare. Congress also has granted deeming authority to several other agencies who can survey on behalf of CMS. So if you say that you have a deemed survey, it means that you are being surveyed by such groups as AAAHC, the Accreditation Commission for Healthcare, Quad A, or the Joint Commission. Those are the 4 that I know of that have deemed status for CMS surveys. And so you apply to them. They have a book of rules for life safety, but they are identical or at least as restrictive as the CMS rules from NFPA 101 and 99. So all of these 4 agencies get their life safety rules about 1 hour fire separation. This is the generator I need. These are my exit lights. This is my sprinkler system. This is my fire alarm system. This is how I think about temperature, pressure, and humidity. These are how I put my hand sanitizers throughout my facility. Those all come from NFPA 101 and 99, which have been adopted by CMS. So they all have standards and elements. And the challenges I see is when I'm out in the field is that people, when I come and ask a question, they didn't even know it was a standard. And so this is where I refer you back to your books. It's an open book test. And so there's a list of things that you need. And if you don't have a list, get a hold of me. I have a list. I will share my list with you. You do not know the intent of the standard. The example is that fire doors are required to be checked annually. You need someone, it could be in-house, who's knowledgeable, to admire the 90-minute doors that you have, the 45-minute doors that you have in your facility that's required annually. And so I've seen some of these reports and there's deficiencies. There's things missing. They don't latch, or the labels are painted, or the rating isn't clear, or it's not the right rating. So there's deficiencies on that report. And the standard says that you will have those addressed, that you need a plan of correction, even on these annual inspections, and you need to get that fixed. Okay, and so I saw a facility that had 2 years worth of door inspections and the same labels were still missing. And I said, you have CMSs, you have 60 days to get that fixed. And they said, oh, we didn't know that we had to fix it. We just had them inspected. So did not know how to achieve acceptable compliance. And this is keeping the documents in some orderly fashion so that when you go down the list of documents, you have them. The most important document that I can talk to you about is the record of completion for the fire alarm system. It's called the fire alarm record of completion. And this happened when your fire alarm system was commissioned. And that is a document you need to have it readily available during every survey moving forward. And so many people have a little box that says fire alarm documentation. And so they just have it in the box and we go and we look and we open it up and we say, oh yes, we have it here. And then not know how to implement or sustain changes. So some things are one and done. If you don't have a pull station at the door, you can put in a pull station and that's going to be there forever. If it talks about managing your eye wash station, or if it talk about managing corridor clutter, where people keep putting stuff in the exit corridor, that's harder to sustain the changes because it requires personnel participation and knowledge. So putting in an exit light, it's one and done. Okay, so looking at generators, people look at generators weekly and they look at generators monthly and quarterly and annually, and then every 3 years. And the biggest challenge I see with outside generators is debris. Debris blown in from neighboring land. I saw a generator that was near a gas station. And so the paper wrappers and things were all around the generator, and the generator needs to be clear of combustibles because the generator gets hot. And then when we open the generator and take a look inside, you can see leaves and debris inside the generator. Okay, so when people are looking at that weekly, that needs to be cleaned weekly because the generator, if it runs and you need it, it's going to be hot. And you just don't want a generator fire when you have people under general anesthetics. Next slide, please. Challenges of managing life safety in an ambulatory surgery center. You all have many hats to wear, and you all may not have facilities people who can help you out with these questions. And so that is the biggest challenge I see. So my suggestion is considering checklists for weekly and monthly testing. What I see is people aren't doing the monthly inspections that are required. They have vendors that come in and do annual things for medical gas, fire alarm, potentially quarterly for sprinklers. This is the outside vendor that comes in and does these things, but there's a lot of inspection elements. So you have inspection and you have testing. There's a lot of things that need to be inspected and documented weekly and monthly. My recommendation for you is keep all of your commissioning documents handy. So this would be all of the life safety plans and then all of the commissioning documents, especially if you're going for an early option survey. So what do I mean by commissioning documents? Somehow the generator was tested. So there is a special page that people signed off that said that the generator is working, the generator was tested for the right amount of time, and that the generator annunciator is all hooked up and all is well. And that's usually signed off by an electrical engineer or the city or all of those people. And so that is a document that you want to keep handy. You want to make sure that all of your outlets are tested when they are installed. GFCI, hospital grade, regular outlets. When the building is built, you need to have those all tested. So you're checking for polarity, you're checking for grounding, and you're checking for the resistance of how hard is it to pull the plug out of the outlet. All right. And so when I go and I say, so where was the blessing of all of your outlets that are in the facility? And people don't know. And then when you talk to the construction people, they don't know. And then it's a finding, and then you have to go find it. So I'm just saying, consider keeping those documents all in one location that are readily available. Ensuring smooth transition between construction and occupancy. I just surveyed a place that had been, was doing an early option survey. And so the construction people were doing all of this testing. And now the ambulatory surgery center was responsible for things like the quarterly sprinkler testing. Now, they didn't physically have to do it, but they sure needed to hire a vendor to come in and do it. And so they didn't know what they didn't know. And this goes back to checklists for weekly, monthly, quarterly, and annual inspections. And these are not things that you need to physically do, but you need to physically have a contract with someone who follows the NFPA guidelines, meaning that they are testing to the addition of NFPA 72 for fire alarms, NFPA 25 for sprinklers that are listed in the 2012 Life Safety Code. Schedule damper testing from 1 year from installation, not building occupancy. So when I come, I see buildings that are like 18 months old. And so I say, where's your 1 year damper testing, smoke and fire damper testing? And so it's 1 year from installation, 1 year from installation, not from occupancy. And then every 4 years thereafter. And verify that there's no penetrations in required 1 hour fire or smoke walls after IT upgrades. The walls are all sealed by construction, and then IT comes through and does all of the data drops, and they're not sealing the conduits that are going through the rated walls. And so it's manner and degree. So we pop the ceiling tiles and we take a look and we count how big are the holes and how many are there. And so if you have enough manner and degree, it could be a condition level finding. And so this is just one opportunity to manage those holes in walls as you move forward. And so periodically somebody should be popping the ceiling tiles and taking a look at that. Next slide, please. I think we're to frequent findings. Battery generators on the weekly check. Frequent findings. Batteries on the weekly checklist. Somebody needs to take a look at those batteries every week. The generator annunciator is tested monthly. So that's the generator panel that lives usually near the nurse's station. There's a little push button area. Med gas alarms are tested monthly. And so if you have a duplex system, meaning you have those big H tanks that are in some room, and you've got 3 or 4 on one side and 3 or 4 on one side, on the other side, those all have, that's a type 1 system, and they have area alarms, and you need a minimum of 2. And the newer ones have a push to test button, and a new log just came out for your review if you are doing that. So you just push the medical gas alarm test button monthly, and you should have a visual and audible alarms that's saying that your panel is working. And so the question that came in is, I have an older area alarm and it doesn't have a push button. Do I need a new panel? And the answer is no, you do not. If you have an existing system without a button, you can continue to use it as long as the authority having jurisdiction, whoever does your survey, says you're still good to go. But you want to ensure that those area alarms are well documented on your annual med gas inspection. Medical gas rooms. If you are existing, you can have a 45-minute door. And so existing is that July 5th of 2016 date. You need 1 hour construction required. If you are new, you need a 60-minute door, and those only come in metal. Those are all metal doors. No wooden doors are 60 minutes. And so the challenge is the lay-in ceiling and then the base cove molding that are in those medical gas rooms. You cannot have any combustibles in that room. And that's a very frequent finding that I see, especially in new. Fire extinguishers, somebody needs to check them monthly, and it needs the month, date, and the year on the tag for each month. Wall signs for recessed fire extinguisher cabinets. So many of the fire extinguisher cabinets now are recessed to allow for that corridor exit clearance. And so you can see this picture of this fire extinguisher sign that you hang up near the ceiling, so that when you look across the hallway, when you look across the room, people can readily locate that fire extinguisher, because when they're recessed, you can't see them. Oh, in the bottom picture, you have pictures of duplex systems. There's oxygen in the green containers on the left, and the nitrous in the duplex system on the right. And that's considered a type 1 med gas system, for which you need those area alarms tested monthly. And you can see that there's nothing in the room that's combustible. Emergency egress lights tested 30 seconds monthly and 90 minutes annually. I see that people are not doing the 90 minutes. So you have the advantage in an ASC where you can just flip off the breaker for the lights. And what happens is you flip off the breaker, and all of those emergency lights, 1 in every OR, 1 in every procedure room, 1 by your transfer switches, and 1 by your generator at a minimum, come on, and that battery sustains them for 90 minutes. And if it doesn't sustain the light for 90 minutes, the batteries need to be replaced. 90 minutes is the time that's allotted so that you can finish a procedure if you're in those sensitive areas and the generator doesn't come on. So these are backups to generator lights. So you've got your normal power, you're doing your procedure, right? The normal power goes out, the generator fires up, something happens and the generator doesn't start. Then these are the backup lights to allow you to finish the case, package up your patient, and evacuate the building safely. We talked about the generator lights by the generator and the transfer switches. Annual eye wash inspections. Most of the places I go, they have the eye wash station in the decon room, right? And so ANSI Z 358.1 2014 requires annual eye wash inspections. And so potentially that includes temperature, but it always includes flow, and it always includes cleaning of the eye wash pieces itself. Bottles are never an eye wash station. Those squeeze saline bottles are never an eye wash station. An eye wash station needs to be activated in one motion for 15 minutes, hands-free. And the moment I have a bottle in my hand, I can't do it hands-free. And then GFCI, those are the little red outlets that may be in your ORs and procedure rooms. And those need to be tested monthly per the manufacturer's instructions for use. Next slide, please. Now we're to questions. Please put your questions in the chat.
Yes, if anybody has any questions for Marge on any of these topics that we covered today, please feel free to use the Zoom chat. And I will read those questions out loud to Marge, and she will do her best to answer those. So any of the slides and topics that we covered today. Will the recording be sent out to us via email? Yes, Nikib, it will. I will send it to everybody in a blast, just like I did the invite for this webinar today. I will send out this recording probably tomorrow. It will also be in the Help Center under Educational Webinars. We have another question from Juanita. If we don't have the original documents for equipment or construction of the facility, how do we obtain copies?
Okay, so sometimes your state, depending if you're licensed in your state, if you're licensed in your state, they will have copies of your documents and you may be able to obtain it for them. So it depends on how long ago we're talking. So if you have had your med gas inspected and they say you're good to go, all right, then the surveyor probably will not ask for documentation that the above ground and below ground piping was installed as required. The other thing is, go back to your contractor. You know, they may have some of these documents. Would be my thought. So it depends on, are you existing, before July 6th, before July 2016? If you were built 2000 or above, you should be able to get your hands on those documents, either from construction or corporate or from the state.
The next question is from Kay. She asked, do you have a template for risk assessment that you could share?
Okay, so are you talking about the category 1 through 4 risk assessment?
She said yes.
Yes. Okay. Yes, I can. All right. So easy risk assessment questions. All right. Are you using general anesthesia? Yes or no? The moment you say yes, you're a category 1 and you don't have to do it room by room. Okay. If you're not using general anesthesia, okay, so you're using maybe like an endo or eyes or whatever you're using for those kinds of procedures, but you still have a type 1 generator, then you would be category 1 and you don't have to do any further discussion about that. But I will get a risk assessment and send that in. And I will absolutely send you my list of documents. So this is Marge's list of documents that I think you need to have when the life safety surveyor knocks on your door. I will share that.
For whatever reason, my Zoom completely shut down, but it is back up. Marge,
Okay.
can you hear me, Marge?
I can hear you.
Okay, perfect. I'm so sorry. For some reason, the Zoom just completely shut down. Marge, if you were cutting out a lot before my Zoom cut out. If you have a risk assessment template that you could share, if you want to email it to me, Marge, I will share it with Kay. And then Kay, if you will, shoot me over an email. This is Marissa. So shoot me an email just reminding me to get that template from Marge if she has one that she can share. And then
I have a template for the risk assessment that I can share.
okay.
But I'm saying that if you have a type 1 generator, a category 1 generator, so that's the generator that fires up in 10 seconds or less. So if you have one of those, you're a category 1 facility and you don't need any more risk assessment than that. All right. I will send my document list of the documents that I request when I come to survey. I will send that to Marissa also. and she can share that with you. And so this is just an example of some of the things that a surveyor may request.
And then Juanita also asked, can you please share the list that you mentioned?
Well, I'm hoping that's the document list.
Okay. And then let's see, Kay said yes. Nakib said, how is that list going to be shared? Email as well. Yes, Nakib. Anybody who wants that list, just please shoot me an email. Again, this is Marissa. I could probably send it in a blast. I'll have to check with my team, but for now, just shoot me an email if that's a list or a template, or, you know, if you're needing something from March, shoot me an email so that way I can specifically get it back to each of you. Can I please have the list of documents sent to me as well? Yes, thank you. Okay, is there anybody else who has questions? I know a lot of you want that list. So again, make sure you send me an email after the Zoom training today, and let me know that you're wanting that list so I can get it from you, for you from March. The doctors that own the surgery center just bought the building next to us for office space. Can we have a door connecting both spaces?
Yes, you can have a door connecting, but it should be locked in from the ASC into the clinic. That should be locked during hours that the ASC is open.
The next question is from Sean. He says, to avoid needing to do the risk assessment for all equipment supplies stored in 20 to 60% humidity, do we just need to include in our policy that we maintain humidity between 30 and 60, then show documentation that we maintain that?
Yes. So somehow you should be documenting the humidity in each of your OR and procedures rooms daily. And you should be documenting the humidity and temperature of your sterile storage room daily. Okay, you do not need to document temperature and humidity in decon. In your decontamination room, it's going to be humid. It's going to be humid. It's hot, it's humid, it's wet. Okay, and so you just keep that documentation. Some people are blessed with building automation systems that record that for them. And sometimes you just need a monitor on the wall that will give you temperature and humidity. So since you are not open 24/7, my recommendation is, how do I know that the temperature and humidity were good on the days I'm closed? And the answer is, you want a min-max type monitor so that you can push the button and see that the humidity never went over 60 or less than 30. It's no different than a min-max thermometer in your pharmacy drugs or your medication refrigeration, if that makes any sense. But I recommend, if your building can do the 30 to 60, go there, because the risk assessment, I think, is painful.
Taylor, please make sure to shoot me an email letting me know you want to receive the documents. When I close this Zoom today, or if you think of a question after the Zoom today, send me an email and I will get you what you're requesting, or get you hopefully an answer to your question. We have another question here. Do we need to have any signage on the door connecting both buildings?
Yes, you do. And you need to be sure that that door and that separation is 1 hour. You know, they can't just punch any old door in that wall. So if your ASC is abutting a clinic space now, that whole wall should be a 1 hour, a minimum of 1 hour. Okay, depending on your state code, it could be 2 hours separation. And so if you're putting a door there so it's convenient to go back and forth, you need to be sure that that door is rated for the 1 hour or 2 hour separation that's required.
Does anybody else have any questions? We have a few more minutes before we will wrap this up, but if you can think of any questions, just put them there in the chat and we will get those questions addressed.
We've got one here.
We were told we needed to remove our signs off the fire leading into the gas room. Where Where should we put the signs, maybe?
Okay, so let's go back to the gas question. Are they saying that the sign can't be on the door, the med gas sign on the door?
Because we were told we needed to remove our signs off the fire leading into the gas room. She said yes.
Oh, okay, so, we have a sign on the door saying it's not a fire exit. All right, now I gotta back up the bus here to the questions. I think I have too many questions. We have a door that separates the door. We have a door that separates the door and is 1 hour fire rated. Okay, and so are we talking about the med gas room? Are we talking about the connecting buildings?
That's a separate question from Catherine. The first question above that was from Anita. She said, we were told we needed to
Okay.
remove our signs off the fire leading into the gas room. Where should we put the signs?
You can put it alongside the on the wall adjacent. And so it depends on what signs. I usually see med gas signs as being metal. All right. And it says that you need caution, you know, you have gases, oxidizing gases, and no smoking and all of that kind of stuff. I see those on the door itself. If you have other signs like this is not an exit or something like that, those cannot be on the fire door.
And then that separate question was, and I don't know if this person's at the same center, from Catherine. She said, we have a door that separates the door and is 1 hour fire rated. The punch code lock on the door is also fire rated. We also have a sign on the door that states it is not a fire exit. Oh, so I think maybe they are at the same center, sounds like. And then Anita said the metal signs had to be removed in order to pass our fire door inspection.
Okay, so it depends on how the metal sign was attached to the door. You can't do it with bolts or rivets.
And then Juanita said, could it be the 5% rule?
Well, no, that's a different rule. So you can put the metal sign on the wall.
Anita said they use double-sided tape.
Well, I disagree that that sign needed to come off. So let Anita and group, let me verify that that fire door can't have the sign on it and pass the fire door inspection. I have not heard of this conflict of rules. I have not. And so let me check on it and I'll get my answer back to Marissa and she can get out to you. I don't want to misstate, but I'm going to look at the fire door requirements. And I have never had the medical gas sign be removed from a fire door and say that it didn't pass.
So Anita, if you will, shoot me an email, just reminding me to circle back around with Marge in a day or so when she can look further into that and get some more information.
It's a great question and one that I really would like the answer to myself. So thank you for bringing that up.
Does anybody else have any questions before we wrap this webinar up? Outstanding presentation, Marge. Thank you, says Susie Allen.
Well, thank you.
Let's see. Catherine said, we have a door that separates the connecting physician's office and our ASC. The door is fire rated and the punch code lock hardware is also fire rated. We also have a
sign.
Yes. Yeah. We also have a, is that word sign? We also have a sign on the door that states there's a little bubble in the way. We also have a sign on the door that states the door's not a fire door exit because it leads to the physician's offices. I'm just letting the previous person know what we have, that we have a similar situation. Got it. Okay. So Catherine, I think you were speaking with Anita, letting her know about your similar situation there.
Right. And so you can have that door. It needs to be secure somehow. I usually see a sign on it that says authorized personnel only. But if it is not a fire exit, it needs to say no exit. Big letters, no, above the words exit. It cannot say not an exit. That's an OSHA requirement. Life safety says it has to say no exit.
All right, guys, you got about 30 seconds to get your last questions in before we wrap this up so I can jump on another training session. This has
Thank
been-
you all for your time. Great questions. I hope you found this helpful.
Yes, me as well. This has been very informative. Lots of good information here today. All right, so I don't see any more questions coming in. If you guys think of questions, feel free to email me. I'm happy to forward those over to Marge. And again, if you need additional information, email me. But Marge, thank you so much. And thank you to everybody who joined today. We really appreciate you taking the time to join this webinar. Everybody have a great day.
Thank you.
Thank you.
Thank you.